who's joined. Lovely. Paula is my name. I'm one of the advanced nurse practitioners. Some of you may or may not know me. And I work predominantly in the outpatient department. And I'm also a first point of contact if you need any help or advice in relation to anything to do with your spinal cord injury. So Hilary asked me to present today on autonomic dysreflexia. Um, that is a condition that is unique only to spinal cord injury, but only to those whose injury is above the neurological level of the sixth thoracic vertebrae. So if your injury is above the sixth thoracic vertebrae, there is a chance that you may be susceptible to developing autonomic dysreflexia. As Hilary said, I have no problem if you want to, just unmute and ask a question. But Hilary, just in case I miss the raise hand sign, you might just come in. I don't mind being stopped or anything like that, just to let me know
Yeah,
that there's
no
a
problem.
question there, because sometimes it's easier to ask the question as you go, and you mightn't remember it at the end, and I have no issue with that. So, okay, so that's the introductions. So, what is autonomic dysreflexia? If some of you have come through the NRH and you have an injury at T6 or above, you may have already heard of it and may be familiar with it. It is deemed to be a medical emergency and it occurs in individuals with a spinal cord injury, but only those who have their injury at the neurological level of the sixth thoracic vertebrae or above. So, roughly, approximately around nipple line or above. They say nipple line, the end of the sternum, um, can be around T9, but roughly around nipple line or above. Don't use them as exact markers. Is the sixth thoracic vertebrae. Autonomic dysreflexia is characterized by a rise in blood pressure, and generally, most people will get a slow heart rate. Although recently we've seen some patients who can get a fast heart rate, but predominantly people will have a low heart rate with a high blood pressure. As I said, it is unique to spinal cord injury, but only those that are injured at the neurological level of T6 or above. So, and when I say neurological level, what I mean is if your injury is T6, your actual level of injury might be higher than T6 or might even be lower than T6. So it depends when you're examined where that functionality stops with your spinal cord injury. Autonomic dysreflexia is an overactivity of the autonomic nervous system. So when you have a spinal cord injury, your nervous system, your central nervous system is affected. And autonomic dysreflexia is an overactivity of the autonomic nervous system. And I'll explain what that is. So we need to know what causes it and how to attend to the cause so that we can manage the symptoms. So the bladder, believe it or not, is the most common cause. It's the most common trigger for autonomic dysreflexia. So the statistics say about 84 to 87% of cases of autonomic dysreflexia are directly related to the bladder. And they say bladder distension, but there are other bladder issues that can lead to autonomic dysreflexia. So generally the bladder becomes distended, possibly from a blocked catheter, possibly from the tubing being kinked. Maybe you're lying on your drainage bag. It was forgotten to be placed out on the floor on a catheter stand. Maybe the tubing is kinked when you sat out into your chair. The tubing of the catheter got kinked. Or perhaps the drainage bag is overfull and it wasn't emptied and the bladder, the urine has backflowed up into the bladder. And then other things to do with your bladder that might cause it. Sometimes a urinary tract infection can lead to autonomic dysreflexia. Bladder and kidney stones can cause it as well. So if you use a catheter to empty your bladder, whether it's a permanent indwelling catheter or whether you're doing intermittent catheterizations, it can place you at a slightly higher risk of developing bladder and kidney stones. And if any of you've had bladder or kidney stones, they can lead to autonomic dysreflexia. So diagnostic interventions like urodynamic studies, like a cystoscopy can cause it. And even a simple bladder washout can cause it. So really just to think in your heads that it is a painful stimulus. So a painful stimulus, but the stimulus is below the level of your spinal cord injury. So if I had a really, really full bladder and I'm sitting here and I'm talking to you, the longer that I leave it, the more irritated I will get, the more jumpy I'll get. Oh my gosh, I need to go to the toilet to empty your bladder. And although you may not have that sensation after your spinal cord injury to empty your bladder, you can get something called autonomic dysreflexia that can be an indicator that there's something not right below the level of your spinal cord injury. And then the second most common cause is the bowel. And that could include bowel impaction or constipation, digital rectal stimulation. So if your injury is at T6 or above, to empty your bowel, you might have to do digital rectal stimulation to stimulate the reflex to help empty your bowel. And that could cause it. Suppository insertion. So when the suppositories go in, that can cause autonomic dysreflexia. Enemas are also a trigger for AD, and which is why we don't use that many enemas for bowel care in our spinal cord injury patients. Hemorrhoids. So hemorrhoids are, in fact, swollen veins that you can get in your just either inside or outside your rectum. And if you had a sensation, they would and could be very painful, and they can lead to autonomic dysreflexia. And then if you get a tear in your external sphincter, just in the rectum there, it's made up of lots of little skin folds. And if one of them gets torn, that's an anal tear. And if more than one is torn, that's a fissure. And that would be painful if you had normal sensation there. So remember, it's a painful stimulus below the level of your spinal cord injury. So with the bowel, it's generally impaction or constipation. Impaction is a medical word for significant constipation. Digital rectal stimulation, suppository insertion, hemorrhoids, and an anal fissure or a tear. And then we have lots of less common causes. So the bladder, remember, is the biggest one. 84 to 87% of cases is caused by the bladder. The bowel is the second most common one, and we don't have exact percentages as to how much that can lead to autonomic dysreflexia. But there are other things that can cause it. So if you were to develop something like appendicitis, that would be painful. So could lead to autonomic dysreflexia. You may not feel any discomfort in your abdomen because of your loss of sensation, but it may cause you to become dysreflexic. So that might be an indicator that there's something not quite right going on in your abdomen. Other abdominal conditions, like cholecystitis, which is inflammation of your gallbladder, gastric ulcers, those kind of things that would normally, if you didn't have a spinal cord injury, they would be painful, but they may not be felt by you, but can lead to autonomic dysreflexia. So fractures, particularly fractures in the lower legs, again, you may not feel them, and a lot of our patients who have spinal cord injury and their bone density may not be as strong as it was before their injury, and it can put them at a slightly higher risk of developing a fracture. So if they were to develop a fracture, perhaps, they may not feel it. Certainly there might be swelling. And although you may not feel pain, you may get autonomic dysreflexia. Skin-related conditions like a pressure sore, an ingrown toenail, or a burn. And believe it or not, we've seen an increase in spinal patients sustaining burns from the heated seats in cars. So a lot of the new cars have these lovely heated seats that you can turn on in the wintertime. But if you don't have good sensation, you need to remember to turn them back off again, or certainly to turn them down to a low heat, because if you don't feel when your skin is getting very hot as a result of the heaters, you could actually develop a burn. And we have had a number of patients sustain quite significant burns from the heated seats in cars. So you just need to be very careful of that. And again, you might not feel the burn happening because of your loss of sensation. So it's just to be mindful of it. Then sexual activity. So if we have a male spinal cord injury patient who's using erectile dysfunction medication to achieve an erection, and the effect of that medication is prolonged, that naturally would be painful. So for our female patients, then, your monthly menstrual period can cause pain. So that can lead to autonomic dysreflexia. And then back to our male cohort of patients, if they were to sit on their scrotum, particularly, sometimes in the early stages after spinal cord injury, you lose some weight and your scrotum can become a little bit looser. And just to make sure you're not actually sitting and you're not putting weight on your scrotum, because that can lead to autonomic dysreflexia. And then for our female patients who've gone on to become pregnant and deliver, obviously labor and delivery is painful, so it technically could be a cause of autonomic dysreflexia. But remember, there's a big long list there. The bladder is the most common trigger. 84 to 87% of cases are directly related to the bladder, whether it's a blocked catheter or whether it is an overfull drainage bag or a urinary tract infection. The bladder is usually the biggest trigger, with the bowel being the second most common one. So I often get asked, how will I recognize it, and will I know if I have it? And sometimes nurses say to me, if I'm doing training in neurogenic bowel care, gosh, will I recognize that the patient is developing autonomic dysreflexia? And I can assure you that you will. And in fact, years and years ago, we used to have a rehab consultant here who used to clamp patients' catheters and sort of induce autonomic dysreflexia so that the patients could experience it before they were discharged, if in fact they hadn't experienced it by the time they were leaving. But we clearly don't do that anymore. But I can assure you, you will recognize it. So generally, the first symptom in the bulk of patients is a headache, a frontal headache here in the front of the head. A severe throbbing headache. And people have said to me it's like a headache they've never had or experienced before. You can get very flushed or a rash on your skin, and this would all be above the level of your spinal cord injury. So if you had a T1 spinal cord injury, this is just below the notch here in the top of your sternum, and you were pale skinned, you could almost have a straight line across your chest, be pale below it, but you could be very flushed and blotchy up on top of it, up your neck and into your face. And it comes as a kind of a blotchy red rash. And if you have darker skin, sometimes that can be a little bit more difficult to see, but you often will see a differentiation. Profuse sweating above the level of your injury. And the longer you leave the dysreflexia without treating it, the more the sweating happens. Goosebumps usually happen below the level of your injury. And then you can get a bit of blurred vision, kind of caught up in your nose, and shortness of breath. But they're more later signs. They don't come in the early stages of autonomic dysreflexia. Patients say to me that they have this feeling kind of that something awful is about to happen, this kind of, oh gosh, I just feel awful. And they get really anxious and, I suppose a bit frightened as well. And that's caused by the autonomic dysreflexia. And then the blood pressure starts to rise, and then they experience a slow heart rate. And then, as I said, very occasionally we're seeing patients that can have a fast heart rate, but the bulk of the patients will have a low, slow heart rate. So we recommend that anyone who has an injury at T12, T6 or above would have a blood pressure monitor at home, a battery operated blood pressure monitor at home. They're not expensive. You can buy them. I saw them in Lidl yesterday for about €17. And if your injury is T6 or above, your baseline, your normal average blood pressure is going to be lower, about 20 to 40 millimeters of mercury lower than somebody of the same age who doesn't have a spinal cord injury. So it's a really good idea and really important, if your injury is T6 or above, to know what your baseline blood pressure is. And all that entails is checking your blood pressure for a couple of days, maybe 5-6 days, and taking an average of those readings. You can buy them in most pharmacies, like lots of places. You can buy them online. Lots of places will sell them. And then just make sure that you know where your portable blood pressure monitor is, so that in the event that you did have a dysreflexic episode, that you are able to access it, pop it on and check, is your blood pressure going up? That can give you an indication that you are developing autonomic dysreflexia. It is a medical emergency. And I suppose the reason for that is that the blood pressure is starting to climb, and high blood pressure is no good for anybody. If it's not treated in, a good time, it can cause you to have a seizure. It could, if it was never treated, cause you to have a cerebral hemorrhage, a heart attack, or even death. Now, thankfully, we've never had any deaths reported in Ireland, or heart attacks, or cerebral hemorrhages as a direct result of autonomic dysreflexia. I have had some patients who didn't recognize that they were suffering from autonomic dysreflexia and went on to have a seizure because the blood pressure rose quite high. But really importantly, the most important line on that slide is if not treated. And I'm going to show you now and go through with you now exactly how to treat an episode of autonomic dysreflexia. So if it happens, if somebody's with you and you're lying in bed, sit up as high as you possibly can in your bed. If you're in a power chair, sit the power chair, put the power chair up into the most upright position it will go in. Because what that will do, when you sit bolt upright, it will actually cause your blood pressure to drop a little bit. So for example, if you were feeling a little bit faint, somebody might lie you down and raise your legs up. So we want to do the opposite to that, and we want to keep the blood pressure down. Call for help. So who's ever your shout out for help, whether it's your partner, in the next room, whether it's your carer, whether it's your mom or your dad, your son or daughter, you need some help to manage this. Okay. So you can ask them, or indeed, if you have the dexterity to do it yourself, loosen any tight clothing. So, if you're wearing an abdominal binder to keep your blood pressure up, open it. If you've got leg straps on your catheter bag around your leg to keep your bag attached to your leg, open them. You can take your shoes off because your shoes might be a little bit tight. And what that does is it allows the blood to pool in your abdomen, in your legs. Lower your legs down if at all possible, and it will actually help naturally lower your blood pressure as well. Get someone to get you your portable blood pressure monitor, or go get it yourself if you need to. Put it on and take a check as to what your blood pressure is doing. And then we need to look for what's actually causing it. And because now the catheter is the main trigger for autonomic dysreflexia, that's where you're going to go to first, is you're going to check your catheter. Okay, so if you're going to check if there's urine in the drainage bag, if indeed you have a permanent indwelling catheter. If you don't and you do intermittent catheters, I would advise you to do a catheterization. Even if you've only done it an hour beforehand, just do it again. Because what that will do is empty your bladder. And if the bladder was the trigger for the dysreflexia, you've now removed the trigger and the autonomic dysreflexia has gone. So empty your bladder with an in-out catheter if you're doing intermittent catheterizations. If you have an indwelling catheter and there's no urine in the bag and you're guessing that your catheter is blocked, we need to make arrangements to get that catheter changed. And that all depends on the arrangements that have been made for you to have your catheter changed on a more regular basis. So it might be the community intervention team, it might be your general practitioner, it might be your partner or your son or your daughter or your mom or your dad, whatever arrangements have been made to change your catheter, contacting them and asking them to help you change your catheter. Some of our patients have suprapubic catheters in. And if you have a suprapubic catheter in, it's no harm to have what we call an intermittent catheter at home, because all that is a thin, flexible tube that you can put into your bladder. You can empty your bladder. It drains into a drainage bag, and you've now emptied your bladder and you've taken the emergency out of the situation, and you can then make the appropriate arrangements to have your catheter changed. So once you suspect it, the bladder is the first port of call to check. So you're going to check for bladder problems. So empty the bladder if you're doing intermittent. Check for kinks. Is the tubing kinked? Maybe it's wrapped around the cat secure that's normally attached to your leg. Maybe the drainage bag is too full and it hasn't been emptied for a number of hours and urine has backflowed back up it into your bladder. And then to change your indwelling catheter if at all possible. Okay. And if it's not possible to change your catheter, there's nobody around you who's been trained in changing your catheter, we need to treat the blood pressure, because if we do not take anything for the blood pressure and we cannot remove the cause, what will happen is your blood pressure will just unfortunately continue to rise. So that's the bladder. So the bladder is the biggest trigger, and a catheter can block, in fairness, at any point. A little bit of sediment can come off your bladder wall and can block your catheter. If you were a known person to have bladder stones, a little bit of the stone can break off and can get caught in the eye of the catheter and can block it. The bowel then, as I've mentioned, is the second most common cause. But the bowel won't be immediate. The bowel is a much more slower burn when it comes to autonomic dysreflexia. So that's why it's really important that you, even if you don't do your own bowel care, that you know that you've had a good result. Because if you are feeling that you might be dysreflexic and your catheter is draining fine, and when your carer or your nurse was with you yesterday morning doing your bowel care, and she or he said to you, Paula, you only had a small type 1 result, which is a constipated result, and you're getting dysreflexic 48 hours later, it's possible that the bowel is a little bit impacted and there's a bit of constipation in the rectum, a bit of hard stool caught in the rectum. So the only way to manage that is that we actually need to remove that hard stool that's caught in the rectum. So we have to check the rectum. So we do what's called a rectal check or a digital rectal examination. So the difference here is that normally when you're having your bowel care done, whether you use suppositories and or digital stimulation, you would use just a water-based lubricant like Optilube, or there's loads of different names of them on the market. The difference with this is we're going to use something that has a bit of an anesthetic in it, like a local anesthetic called lignocaine. And the one that we use here in the hospital, and I think it's the one that's used a lot in the community as well, is something called Instilogel. And that comes in a kind of a syringe-like container with a rubber top on it. And you need to just rub a little bit of that gel. You just take the top off it, squirt a little bit out onto your glove, and just massage it inside the rectum. So you have your rectum here, and you're going to massage it inside the rectum. Leave it for a minute or two, and the local anesthetic in the Instilogel, which is called lignocaine, will actually dull down all of those nerve endings and will allow you or your carer or your public health nurse or whoever it is that is helping you actually remove that hard stool from your rectum. And remember, once you take the stimulus away, so if you get your catheter changed, if that's the trigger, or you remove that hard stool from your rectum, the autonomic dysreflexia is actually gone. And by using the lignocaine gel to help empty the bowel, it actually prevents your blood pressure from rising a little bit more as well, so that there is a rationale to it. If on the off chance, so that you didn't have Instilogel handy, or maybe it didn't go onto your prescription for one reason or another, you still need to empty your bowel and just use the regular gel if that's all you have. So this leaflet was developed by some of the staff here in the NRH, and it goes through the causes, which is the top left. So we have the bladder being the top one. We have the bowel being the next one, and then we have the less common ones such as the skin, and then the other ones like sexual stimulation, labor, childbirth, monthly period cramps, that kind of thing. And then the bottom left is the emergency treatment, and I'm just going to talk about that for a minute. So you now know the first thing you're going to do is to call for help, and you're going to sit bolt upright, loosening any tight clothing, loosening the leg straps, opening an abdominal binder should you be wearing one. If on the off chance you were wearing TED stockings, which some of our patients here in the hospital would be wearing, unlikely to be wearing them at home, to be fair to you, just pull them down. You don't even need to take them off, just pull them right down to the ankles. And that will allow blood to pool in the lower extremities of your abdomen and your legs, and it will help lower your blood pressure. And then we need to find out what the cause is. So we're going to check the bladder. and or the bowel, whichever you think might be your trigger, and you'll have a pretty good indication as to what it is. That said, if you were on your own, you didn't have anybody that you could call, you perhaps even the person that you do call perhaps isn't able to help you check your bladder or your bowel, we need to treat the blood pressure, because if we don't give something for the blood pressure, it will continue to rise. And this uncontrollably high blood pressure is what can cause a seizure. So we need to give a medication called nifedipine. Nifedipine is an antihypertensive. So that's something to take down your blood pressure. And it's 10 milligrams we generally give for an adult. We describe something called the bite and swallow method. So it is a capsule. So it's two halves together with the liquid inside. Put it in your mouth, bite it. The reason for that is it will actually start to be absorbed in your mouth before it goes down into your stomach. But if you do swallow it by accident, if you actually hate the taste of it because it doesn't taste terribly nice, just swallow it down with a drink. If you do use the bite and swallow method, swallow it down before you take a drink and it will work very, very fast. If you swallow it without biting it, it will still work very fast and be just as effective for you. What that will do is it will lower your blood pressure, and it then buys you time to perhaps make arrangements to go to your local accident and emergency department to perhaps have your catheter changed, or to contact your GP or your community intervention team or whoever it is that you normally contact to have a catheter changed. What I will say to you though is that if you do have to go to your local accident and emergency department of your nearest acute hospital, it'd be no harm to bring some information with you on autonomic dysreflexia, because some healthcare professionals will go through their whole career and they'll never be exposed to autonomic dysreflexia. So for that reason, they may not understand it. And they might bring you into the triage room where a nurse would check your vital signs, check your blood pressure, your pulse, your temperature, and your oxygen saturations. And your blood pressure is about, maybe 130 over 90. That nurse will probably find that quite an unremarkable blood pressure. But for you, who's an injury at T6 or above, your baseline blood pressure could sit much, much lower. So your baseline blood pressure, might be 90 over 60. And now your blood pressure is reading 130 over 90. So it is a higher blood pressure. It's not extraordinarily high, but it's high for you. And it could indicate autonomic dysreflexia. So really, because of that, I always encourage all of my patients to learn and to understand and know about autonomic dysreflexia. And although there might be a high element of frustration that you're presenting to an emergency department and the nurse, may never have heard of it, they won't have heard of it unless they've been exposed to it before, because it's not something that's taught in nursing school. It is taught in medical school, but it just, they may not understand it. So don't get frustrated. Just, be in a position to say, could you look up autonomic dysreflexia, because that is what I have. Particularly if you don't have any information with you. The nifedipine will buy you, a few hours of a low blood pressure. But if the cause is still there, so the catheter is still blocked, what will happen is your blood pressure will start to climb again. And if that is the case and you haven't managed to make arrangements to get your catheter changed, whether that is GP, PHN, partner, family member, or ED, you might need to repeat the nifedipine, and you can actually repeat it after 30 minutes. Because nifedipine is an antihypertensive, it may cause you to be very faint for the rest of the day. So, if you were planning on getting up and going out for the rest of the day, you may not be quite as able to do that as you would on a regular day, because your blood pressure is going to drop quite a bit with the nifedipine. The nifedipine works really, really quickly. It was a drug that went into short supply when Brexit came and some of our medications did go into short supply. And then we had to kind of come up, some people couldn't access it at all, and we needed to come up with another alternative. And the alternative was GTN spray. And GTN stands for glycerine trinitrate. And it is a medication That is used by people who have like a cardiac condition called angina, which is where the vessels become tight and the GTN opens up the vessels. So by opening up the vessels, it's going to lower your blood pressure. And it comes in a spray that you deliver under your tongue. However, because there is an interaction between GTN and erectile dysfunction medication, we here in NRH have kept the first line treatment for autonomic dysreflexia as nifedipine. So nifedipine still stays as the first line treatment. That said, though, there are some patients around the country who used GTN when nifedipine wasn't available, and they still are using GTN as their treatment. And there is nothing wrong with that, but you cannot take erectile dysfunction medication if you are taking GTN spray. So just to be wary of that, because it's quite a significant interaction. So that's the treatment. So I just want to talk to you about this leaflet and the piece in the center. So remember, it's a painful stimulus that causes the autonomic dysreflexia. So the yellow bubble in the center is to signify a full bladder. So the bladder is full, and if I had a full bladder and I was sitting here, I'd be getting a little bit more irritated, as you would have been before your injury. So the body sends a message back up the spine to the brain to let the brain know that there's an irritation. There's a painful stimulus below the level of the spinal cord injury. The body responds by constricting the blood vessels, so making them really, really tight. And unfortunately, when you constrict something, you're going to cause the pressure in it to rise. So if you can imagine a hose pipe, and the hose pipe, you clench the hose pipe really, really tightly, the water will come out at a much higher speed. So it causes the blood pressure to climb. And then unfortunately, the message cannot reach the brain because we have an injury in the spinal cord, whether it's T6 or higher. But the brain realizes that there's something going on. And we also have these receptors in our carotid arteries called baroreceptors. And they actually pick up that there's something going on in the body. So they actually try to compensate for the high blood pressure by dilating all of the blood vessels, which is why you get the sweating, the red rash, the blotchy rash, and you get the headache because it's expanding all of the blood vessels. But unfortunately, that compensatory mechanism doesn't work because it can't go back down the spinal cord because of the injury. And unfortunately, we get into that kind of almost a vicious cycle of stimulus being tried to send up the spinal cord to the brain, the vessels constricting, the blood pressure rising, and then the brain trying to compensate for that rise in blood pressure. So that's why it's important to take the stimulus away, because once you remove the stimulus, the AD is gone. Now you might have a bit of a residual headache afterwards, but you can just take a couple of paracetamol and that will take that away to get rid of that for you. So this is a really good leaflet. It's readily available online. It's been translated into a number of different languages. So for those that English is not their first language, they'll have access to something that they can understand as well. If the symptoms persist and you don't know the cause, so if you look at your catheter and your catheter is draining and nice warm urine in the bag, nice clear urine, and you had a good result from your bowel care this morning, you're just unsure what the heck is going on here now. How could I be dysreflexic? Who knows? Maybe there is something going on in your abdomen, but take your nifedipine, because the nifedipine will lower your blood pressure and it will allow you time to perhaps make arrangements to go see your GP or go to the emergency department. And I always say to people, if your blood pressure doesn't settle after you take the nifedipine, you do need to go and see somebody. So you do need to either go see your GP or perhaps go to the emergency department. The nifedipine should go on your prescription, and you should get it when you're getting your prescription renewed. You only need to have about 3 tablets at any given time. So just be careful when your prescription is being renewed on a 6 monthly basis that the GP doesn't leave the nifedipine off it, because some people will never need to use their nifedipine because they will never get dysreflexic. And then what happens is it gets left off in error off their prescription. The other thing to do is to keep an eye on the expiry date of it. So if it's coming close to being expired, you might need to replace the stock that you have at home. If you had an expired medication, it will still work for you. So if you did get dysreflexic and your nifedipine is expired, you can still use it. That did happen to me one time. I was with a patient, and when I checked the expiry date, it was expired, but I had no option. I still used it, and it worked. It worked beautifully and took the blood pressure down. So how to prevent it happening is you need to keep your bladder well flushed, drink. You'll have heard that if you've come through the NRH. Pay good attention to your bowel program, and if you're noticing that you're starting to become constipated, you might need to increase your fiber, you might need to increase your laxatives. So just to make sure that you're keeping a close eye on your bladder and your bowel program. Check your skin. Check your skin morning and evening, whether it's with the camera on your phone or a mirror. Check it. Know what your baseline skin looks like, so that if you develop any red marks, although the skin may not be broken, there could be like a deep tissue injury under there that is causing you to become dysreflexic. Make sure your nails are attended to. Try to see a chiropodist, maybe once a year if you can, so that you're not developing ingrown toenails. Avoid extreme hot and cold. So sometimes people say to me, if they've been inside in a warm building like a hospital, for example, and they go outside and it's bitterly cold outside, that sudden drop in temperature from hot to cold can actually cause them to be dysreflexic. Very rare, but occasionally some people can complain of that. Take your prescribed medication. So maybe you're already on an antihypertensive, because people who get spinal cord injury are not immune to developing high blood pressure. So you may already be on an antihypertensive. And if you are and you get dysreflexic, you still need to take the nifedipine. And if you're concerned or you have any worries or anything like that, you're more than welcome to contact me or link with your GP, either, if you're more comfortable doing that. It is recognized as a medical emergency, and if you have to go to your local accident and emergency department, use your own education now and your own knowledge to alert the staff there that this is a medical emergency, that if you don't get treated, as in you don't get your catheter changed, you are at risk of your blood pressure rising even further. It's up to us all to promote the knowledge around autonomic dysreflexia amongst the spinal population. That's why it's great that Hilary can organize these type of webinars, because information is power, and power is what will help you get treated. Early recognition. So, if you're recognizing very early that your catheter is, starting to drain ever so slowly, you might be starting to block off. Maybe you need to drink a little bit more and then maybe do a bladder wash. So early recognition and prompt treatment is really, a good tip to take away from today. And be aware and be prepared. And that's my contact details there. Hilary, I'm sure will be happy to share them with you. If you do have any questions, I'm going to stop now and take questions if there are any, but maybe you're not comfortable asking a question on a forum like this. You can let me know if there are any questions.
I don't know if anybody has any questions here. Paula, can I actually ask you a question?
Sure.
And I haven't planned to ask you, I hadn't asked you this before, so you don't know what I'm going to ask you. Um, what what's the percentage of people with an injury T6 and above that are susceptible to this? Is it very high?
You see, it's different, Hilary. There are no percentages actually documented as to, how many, will 1 in 10 patients with an injury T6 or above develop it. because everyone's nervous system is very unique and individual. And years ago, it used to be always thought that the complete spinal cord injury, like the Asia A's and the Asia B's, would be more at risk of developing autonomic dysreflexia, but that's kind of changed now. Now, it's less common if you're very incomplete, so you're kind of in Asia C, D, it's definitely less common. But if you're using a catheter to empty your bladder, you're never exempt from the risk of it. You know what I mean? So there isn't, I can't give you a definitive number, Hilary, but I can say to you that the risk is lower with a kind of Asia C or D, but it's not completely excluded.
Hmm. There's a question there from Jane. Why would I have AD on one side only, sweating profusely at night, but just on the right side? Blood say everything is okay.
Yeah, so that may not be AD. That may be just your autonomic nervous system being a bit sensitive. If your blood pressure is staying okay, it's probably just what we call autonomic symptoms. And although I'm saying just, I'm not diminishing it by any matter of means. If your blood pressure is rising, we could maybe treat your blood pressure and it might dampen down that sweating. But if your blood pressure is not rising, there isn't really a medication that we can give for it, but it might be an idea to maybe do a 24-hour blood pressure monitor, because at some point during the day you may be spiking, and it may be, if we have a record of maybe you're spiking at in the evening time or in the morning time, or there's a particular stressful time of the day for you, you might need to go on a low dose antihypertensive for that. That will dampen down those symptoms. But that can be very hard. I was talking to a patient the other day who said, when she sits bolt upright in her chair, or maybe even on an airplane seat, or that kind of thing, that she gets this profuse sweating, and her blood pressure isn't rising. So they're just autonomic, and I don't mean just as in a belittle of it. I mean they're autonomic symptoms. It's not full blown autonomic dysreflexia. It's an irritation to the central nervous system. Really, that's what that is. So I would say keep an eye on your blood pressure, check your blood pressure when you're getting those symptoms. If your blood pressure is not rising, it might be an idea to maybe have a 24-hour BP monitor, or just link with us or link with your GP.
There's Jared. I'm just gonna if you want to your question there, Jared, if you want to unmute yourself, because you're muted there. Let me see.
Okay.
Jared, do you wanna ask your question there?
Yeah, yeah, please, Hilary. Paula, the question is, I have recently experienced a cold feeling throughout the body, just cold for no reason at all,
Yeah.
and clamminess, a kind of a, not
Yeah.
sweating, but a damp
Yeah.
sort of sensation. And I wonder, is that autonomic dysreflexia?
And Jared, can I ask you, before I answer that, you'd know symptoms of like a urinary tract infection or anything like that?
I have a slight pressure, well, it's not a pressure sore, but it's a pressure point on
Okay, okay.
my experience.
Yeah. So unfortunately, so it probably isn't full blown autonomic dysreflexia, as Jane was asking there. It probably is an irritation somewhere. Whether that is, what can happen with spinal cord injury is that when I sit or you sit, I have lots of fat in my bum, and that protects my bones rubbing against my skin. And unfortunately, with the spinal cord injury, sometimes the glute muscles, the bum muscles, can you lose bulk in them over years. And when your skin is you're sitting, and your sit bones are almost sitting on your skin, so to speak, because you've lost bulk in your muscles, that can cause your skin to be irritated or get this type of a pressure point that you're referring to, Jared. And if you had normal sensation, that would be uncomfortable, and you'd probably find you're shifting your position a little bit more than normal. And that could be what's causing it. It's very hard to say exactly, kind of on this type of a form, what might, if that is the actual cause of it. those symptoms are indicative of, like a low-grade infection as well, like a urinary tract infection or maybe a chest infection, without kind of having all of the full-blown symptoms of it. But if that kind of doesn't resonate with you, Jared, you're welcome to get back in touch with me. You could try to delve a bit deeper, between the two of us and see if we could find a cause for that. But it is definitely what we call autonomic symptoms. So it generally is indicating that something's not 100% in the body.
Yeah, my bowel system wouldn't be as good as it once was.
And that's
Uh,
normal, Jared, because the bowel slowing down is part of the neurogenic bowel with a spinal cord injury. But as we age, then, as all of us age, part of the aging process is that the bowel becomes slow. And if you're balancing a spinal cord injury plus aging, as we all are, unfortunately, the transit time, the speed that your bowel moves at slows even further. So, you may need to maybe change up the medications or the timing of the medications for your bowel. Like if you're taking Senokot or Dulcolax to help speed up your bowel, maybe take them a bit earlier, Jared, and see you're giving them a longer time to work, and it may help push the stool onwards in your colon and give you a better result. Because indeed, that slow, sluggish bowel could be what's causing those symptoms as well.
and what about gas? I experience
Yeah.
during the day an awful lot of
Yeah,
gas.
the gas is a problem because you can't control it. So it's embarrassing, number one. And number two, then, if your bowel is gone very, very sluggish, you will develop more gas. So have a look at what you're eating as well, because you can't really stop the laxatives because you need them to help the bowel to move. And if there's any particular dietary triggers that is triggering you to have that increased gas, just try and identify it. It's not an easy solution, Jared, to be honest with you. A lot of spinal patients will experience that, and it can be very challenging to manage.
Thanks, Paula.
Oh, no problem. Jared, if you want to even give me a shout, do so, please.
I will, yeah. Thanks.
Yeah, okay.
I don't know if we have any more questions there. Just to echo, I suppose, what Paula was saying about the leaflet that the NRH have. We have, I know this is backwards, or it might be forwards, I'm not sure on this.
No, it's good, Hillary. Yeah,
Oh,
it's
grand,
good.
good.
Good way to check.
We have these wallet size, they're kind of little plastic cards. So just so people can see them
Yeah.
there.
And that's the kind of thing, Hillary, that if, they had to go to an emergency
Yeah.
department, that they could bring with them, because everyone's always has their wallet with them. So I think that's essential to
Yeah.
have. So, if Hillary would post some of them out to you,
Yeah, if
one out to
anybody
you.
wants them, we all of the community outreach officers would have them. So even if you ring the office here or email info@spinalinjuries.ie, we can post them
Yeah.
out to you. They're very
I think
handy.
they're very handy. Yeah,
Yeah.
I'd echo that. Yeah.
Yeah. Just you may, as Paula says, you may never, it's like the nifedipine, you may never need it, but just in case
No.
you do, it's
Yeah, exactly.
yeah, they're very useful. Yeah, I don't think there's one. There's another question here.
Okay.
Hold on. Jane was saying acupuncture really helped her manage gas.
Oh, very interesting,
Yeah.
Jane. Yeah. Yeah.
We had a really good conversation actually the other night at the manual wheelchair user Zoom. Jane was saying about how acupuncture had really helped her. So it was very
That's
interesting.
very interesting. I'm glad. Again, good to know, because it's nice to be able to give somebody something that might help them,
Yeah.
as opposed to saying, no, there's nothing,
Yeah.
So,
Or here's another drug.
yeah, exactly.
Yeah.
That's going to cause another side effect,
Yeah.
whereas there wouldn't be any from acupuncture,
Yeah.
So that's helpful. Yeah.
Yeah, it's very interesting. Yeah, I don't think there's any others forthcoming, but as Paula said, she's very contactable, and like we are as well, to point to the NRH
Yeah.
for support. So yeah.
Absolutely. If this, because sometimes, you don't want to ask something as personal on a forum like this, Hillary, so
Yeah.
I've no issue if any of the attendees want to give me a call.
Yeah. There's another one there, another question. It also said she also got my guts moving again normally.
Good.
So,
Good.
yeah.
That's what we all want, isn't it?
Exactly.
Yeah,
Yeah.
exactly.
So no, that's really good. Well, listen, Paula, thank you very much for your
You're
time,
very
and
welcome.
thanks to
Great to
everybody
have everyone. Yeah.
for listening. So I'm gonna stop recording now.